So I'm not gonna lie to you. I tried starting this video like 6 times and realized that I always say the same thing every time I try to start a video, which is basically cool. All right, let's do this. Blah, blah, blah. Let's dive in. All right. So we're gonna try something new and say, let's get started. So today we're gonna talk about types of joints. Um, we talked about bones to then talk about joints, which makes sense because essentially what a joint is it is a site of articulation between two or more bones. The point of a joint is, poet and didn't even know it. The reason for a joint is to allow for a freedom of movement, a degree of movement. Not necessarily every single type of joint allows movement, but most do allow movement, whether it's a restricted level of movement or it is essentially a free level of movement, such as you get from like ball and socket joints at the hip and at the shoulder. The skeletal articulations and the joint articulations are largely classified according to two different methods. The structure of the joint or the function of the joint, and they're different, but they have some homogeny about them. They have some similarities about them. So if we're going to be classifying joints based on structure, we're going to be saying that they're fibrous, they're cartilaginous, or they're synovial. If we're talking about the function of joints, they're going to be synarthrotic, amphiarthrotic, or diarthrotic, or synarthrosis, Jance, amphiarthrosis. I can't say these words, so I apologize. I'm going to butcher them all the way throughout the lecture. Amphiarthrosis or diarthrosis. Like I just said, there's a strong relationship between the structure and the function, functional definitions for these, or structure and functional nomenclature backgrounds for the joints. Synthroid joints, and as I say that, we're going to be using, for the most part, the functional definitions and functional classifications, I guess is a better way of putting that. It makes more sense in a kinesiology-based class, or structural kinesiology class, if you will. So synthroid or synthroidal joints are largely divided into two different types of subgroups. So you're going to have a suture, which is essentially immovable joints. So it looks like someone's had stitches ran through it, right? An example of this is the cranial bones. So there's actually several different bones that make up the cranium, or the upper part of the skull. And you're going to have gomphosis, which are essentially like your tooth sockets. And it's where, and what it means is that it's a conical peg that fits into the socket. So if you think about the structure of a tooth, it kind of fits down into a socket, if you will. Amphiarthroidal joints are going to be our slightly movable joints, and you kind of put one of these things on there, right? Like kind of I give it some squiggles. So there's syndesmosis, symphysis, and synchondrosis. Syndesmosis joints are held together by ligamentous structures. Good example is the corticoclavicular joint, and then the inferior tibiofibular joint. So if we kind of walk through these things, you've got the inferior tibiofibular joint. So where is that going to be? Is it going to be high or is it going to be low? It's going to be lower. It's going to be more towards the ankle, right? It's going to be more distal, if you will. It sits below. And then you've got the tibiofibular joint. So it's going to be between the tibia and the fibula. The corticoclavicular joint fits between the coracoid process and the clavicle. All right, so over here, I don't know if you can see that. Sorry. You're going to have the symphysis. So think pubic symphysis. It's going to be a joint that's separated by fibrocartilage pad, very slight movement between bones. So you can actually, like if you think about the pubic symphysis, if you go all the way back to anatomy, there is a layer of fibrocartilage that kind of sits in that area between the two sides of the pubis. And there can be like this slight little bit of movement back and forth. Same thing with the intervertebral discs, right? Like you can kind of have some slight movement, but it's not much. And then synchondrosis, joints separated by hyaline cartilage. So that's the costochondral joints. of the ribs and of the sternum. So it's going to be kind of where your ribs meet your sternum. So right here. True story. I sprained something inside of my chest. I can't remember where it was, like what rib head it was, but I ended up having to get a cortisone shot in my chest, which is a big needle going into your chest. It's not a fun experience. Arthroidal joints doesn't mean it's arthritic, right? But arthroidal joints are going to be our gliding and our sliding joints, typically characterized by two flat bone surfaces. Remember where those flat bones are, right? They're going to be in the hands and in the feet predominantly. You've got limited amounts of gliding, because remember, like those flat bones, the goal is to interact with each other and kind of provide more articular surfaces about each other. And then we kind of get into what I think personally is the more fun joints, which is our diarthroidal joints. So these are going to be our freely movable joints. Typically, they can be called synovial joints because there is a synovial fluid that is going to be present inside of the joint capsule. Same thing, there's going to be a synovial membrane. And that synovial membrane, synovial capsule is going to almost act like a sleeve around the joint capsule. And if you look over here, you can kind of see that there's this like synovial membrane, and you're actually creating a joint capsule around the joint. Some of those areas are going to be thickened and a little bit like non-elastic, so they're providing some structure and some stability there. These diarthroidal joints are going to have articular surfaces on the bone ends, right? So very good example is the femur, right? It's got articular surfaces on both bone ends. It's got where it inserts for the ball and socket, and then down distally or inferior where it articulates with the knee joint, right? So there's going to be an elastic and a slightly compressible feature to these joints, so you can actually manipulate the joint a bit. And that's largely due to the fact that there is a synovial fluid that is secreted inside and released inside of that joint. And there's also that cartilage. So it's creating this like very low friction environment. I almost was going to say like soapy, but it's not like that at all. It's a lower friction environment, so that there's a freedom of movement that can occur inside of the joint. And while that's important is because when we're not loading the joint, so a great example would be the short sit position with feet not on the ground. So think your femurs are on a chair, your shin, your tibia, fibula are hanging off of the chair, and your knee is unloaded, right? There's not an external load being applied to your knee joint. The cartilage can actually absorb some of that synovial fluid. And whenever there is a weight reapplied, like you hop out of the chair and you stand up, you're going to compress that synovial. You're going to compress that cartilage and re-release that synovial fluid. And why that matters is because there's really not a whole bunch of vascularization and blood flow inside of joints. And when it gets reabsorbed and then resecreted, it's a chance for blood flow and an exchange to occur, if that makes sense. So, like I was saying earlier, the diarthroidal joints are freely movable. There's a lot more movement potential there than there is in the other types of joints. And it largely, that level of movement is going to be determined by the number of planes that the joint can move in. It sounds so common sense, but you got to think that it's not, right? So what are the cardinal planes of motion, right? We have a frontal plane, we have a sagittal plane, and what else do we have? It's a lot less cool to ask questions on a YouTube video. I will say that. We have a coronal plane, right? So we have these, or transverse, coronal slices, transverse plane, same thing. So you have frontal, sagittal, and transverse planes for movement. So if a joint can only move in one plane, if it's only a frontal plane joint or it's only a sagittal plane joint, how much angular freedom does it have? Well, not a whole bunch, right? It can only move in one plane. It can only go flexion and extension. It can only go this way. It can't go ridiculous. I apologize, but essentially the number of planes that a joint can move in determines how much it can move. So think the knee, right? Largely, the knee is moving in the sagittal plane, right? Like there is very little amount, if any, of frontal plane motion. Ideally, there's not really any. Whereas the hip, something like the hip or the shoulder, you have flexion extension, so you have sagittal plane movement. You have abduction, abduction, and you have adduction, which is bringing it back in. Like, right, you're away from the body, AB, and you're adding it back to the body, adduction. So AB away from the body, adduction towards the body. So you have frontal plane motion. And then you also have the ability to go transverse plane because you can lift it up and you can go horizontal abduction and adduction as well. So really the cardinal planes and the vectors of movement are going to determine how much joint freedom there is. In terms of diarthroidal joints, you're going to have a couple different types. So you're going to have condyloidal joints, and think of this as a flask in a cup. So it's kind of like sitting inside. Great example is where the metacarpals and phalanges meet. So you can see that you kind of have this like flask structure here and then a cup structure here. So it allows for an articulation surface. You're also going to have your anarthroidal or your spheroidal or your multi-axial ball and socket. Great example is the hip joint. So it's going to be where the femur actually is able to fit inside of the pelvis and articulate fairly freely. You are allowing for movement in all planes. So you have transverse plane movement because you can lift your femur up into flexion, or you can lift your hip into hip flexion, which is out in front of you, and then you can rotate that femur out to the side and back in. So you have horizontal AB and adduction, and then you have flexion extension, and you have regular abduction and adduction. So it's truly all planes of movement are expressed at the hip as well as at the shoulder. Ligaments is a hinge joint, and a great example of these two are the elbow and the knees. Wide range of motion, right? Like it's essentially 180 degrees of motion. Not quite, but you can bring from full extension to full flexion, and that's about it. There's not much outside of that you can do. There's sellar or saddle joints. So this is going to be where those flat bones of the hand actually start interacting with the bones inside of the fingers. So you can see that it's kind of like this saddle. Oh, I don't know where my cursor is. There you go. There's like an interface and a saddle that you sit on. Same thing, right? Like kind of a joke here with a skeleton on a saddle, but it is a type of joint as well. You have trochoidal. These words are hilarious to try to pronounce when you're So we also have these kind of like pivot and screw joints, or these trochoidal types of joints, and they're largely this like rotation based. So it's kind of like you're screwing in. A great example of this is the radius on the ulna at both the proximal and the distal sides. So it's the reason why you're actually able to take and rotate your radius over your ulna, which goes under, right? Like that's a great way to remember the radius and the ulna, but also helps you remember kind of what this pivot or screw joint does, is because it allows for this level of rotation. And you can tell by looking at the joint interface that you are the only thing that's really going to be able to happen here, because of the ligament. You're not going to be able to come out like this, right? Like you're not going to have this adduction. One, it's got a ligament wrapped around it here, but then two, when you go to the distal section of it, it's also attached. So it's only going to be able to really rotate. So it'll only be able to come over. So that would be a trochoidal joint. So whenever we start getting into these freely movable joints and the ability of the joint to move in various planes, regardless of if it's in one plane, or it should be in one plane, or if it's able to move in all three planes, we need to discuss both the stability and the mobility of a joint. And we'll get into those. But generally, as the mobility of the joint increases, the stability of the joint decreases. So we need to have a certain level of both stability and a certain level of mobility. And again, we'll talk about those in a little bit. But essentially, when we're talking about stability and mobility, we need to be talking and thinking about Davis's law. If you know Wolff's law, you know Davis's law. Same concept, except instead of bones, we're looking at soft tissue. So essentially, you got soft tissue adapting to a level of stress. So if a tissue is continuously stretched or stressed, it will eventually lengthen. Same thing is that if it's continually loose or shortened, it will shorten. So think about what happens when you are constantly sitting down. If you're constantly sitting down, you tend to see people start to develop an anterior pelvic tilt, right? Like they're compressed between their femurs and their torso, right? So their lower appendicular skeleton is going to be in flexion relative to their axial skeleton, and you're actually going to have a level of shortening that will occur in the soft tissue that spans the hip joint on the anterior side. And that, whenever someone stands up, you can actually see has taken and rotated their pelvis forward some, right? And if you remember, we talked about kyphosis and lordosis. Well, kyphosis is this like rounding of the upper back and protraction. That lordosis is also, it's like the movement of the lower back forward. And that's kind of something that you get when you have this over-tightened anterior hip capsule. 5 factors are going to affect the total stability and mobility of a joint: bones, cartilage, ligaments, muscle, proprioception. Just like I do every time, we're going to go over each one of these individually. So when it comes to joint stability, what role do bones play, right? Think anatomical configuration here. Think how much room do the bones have to articulate on each other, and how much protection essentially is afforded for stability, right? So think about how snugly the head of the femur fits into the pelvis, or into the pelvic girdle. Think about how deep that joint is, right? Like, I mean, it is a deep joint. The depth is there. If you think about an elbow, really the articular surfaces aren't super deep. They're deeper than some joints, but they're not as deep as something like the interface for the hip joint. So the less structure that the bones can provide, the less joint stability from the bones. When it comes to cartilage, hyaline and cartilaginous tissues can help kind of form a joint congruency. And it almost sounds counterintuitive at first, but when you kind of think about it, and when you look at these pictures right here, it kind of starts to make a little bit of sense. And these are like osteoarthritic or arthritis looking joints over here. But what you have is you have these articular cartilages, right? So you have this ability to create less friction and pad, and you increase the padding and stuff like that. But what you're essentially doing is you're creating a cleaner articular surface, and you're actually increasing the joint congruency and stability because you're allowing for a higher level of joint interaction, if you will, and it makes a cleaner joint. Whereas if you get into this area where there's like no cartilage, you can see how it's essentially just smashed down on top of the other bone, and it's not really fitting into the articulating surface super clean, and it's kind of just smashed together. So that cartilage is going to really enhance the joint congruency and make it a cleaner articulating interface, if you will. Ligaments also provide a ton of structure and joint stability to different types of joints. A great example of this, I think personally, is going to be the knee, because look at all of the ligaments that you have running across the knee, right? So we have ligaments that try to protect the knee and ensure stability for just about every single vector of movement that we possibly can have, every single level of plantar movement. So if we have sagittal movement, we're covered with ligaments. If we have frontal plane movements, we're covered with like the lateral collateral ligament and the LCL or the MCL, right? Like the goal is to try to minimize the risk of hypermobility or minimize the slipping out of the joint, if you will. Same thing with muscles. Again, I come back to the lower leg because I think that it's a great example of how much stability that you can bring to a joint with muscle. If you think about the quads and you think about the hamstrings, they're able to, they span the knee joint, right? So the quads and the hamstrings span the knee joint, and they actually insert onto the lower leg. And so you have a large mass of muscle that is extending across a joint and covering and enveloping a joint and providing a stability to that joint. While the muscle and musculature might affect the overall joint range of motion, it can improve the stabilization of the joint. Also, you're going to have proprioception and motor control. So if an individual has very low proprioception or very low kind of like control of posture and movements, they're going to be more likely to experience joint-based problems. What I mean when I say that is so there's a big thing also is going to be proprioception and motor control. And proprioception is going to be this kind of like subconscious control of our body and the way that our body interacts with the environment, if you will. So there is a full conglomerate of sensory organs and sensory tissues that exist within our muscles, inside of our ligaments, inside of our joints, that respond to stretch, they respond to contraction, they respond to force, all these different things. And essentially they're sending signals to our spinal column or to our brain to say, hey, I'm in this position. Hey, I'm in this position. How am I going to contract? How am I going to move? Because if you have an incorrect amount of movement that is occurring, if you have the incorrect response to a stimuli, you could put that joint at risk. Joint stability and joint mobility really brings us to this concept of open packed versus closed packed joints. For some of you guys, this might not be the most unfamiliar concept. To some of you, it could be a brand new concept. An individual that really talks about packing arms and or packing joints and packing hips and stuff like that is a guy named Kelly Starrett. He's a physical therapist. I believe he's out of California. He wrote a book called The Art. I think it's not The Art. It's called Becoming a Supple Leopard. Great title. Actually, on the book, he talks quite a bit about open packing and closed packing joints. But essentially, what you get in a closed packed joint is you're going to get maximum contact area with the bones. So you're going to be placing the bones in a maximal contact, maximal surface to surface position. And that means that you're going to have the maximum amount of stability, and you're going to have the minimum amount of mobility. So in a closed pack, minimum mobility, easy way to remind it. In an open pack, you're going to have, or a loose pack, if you will, you're going to have less contact area in greater levels of mobility and lower levels of stability, if you will. And that's what you're seeing here, right? So you're seeing this kind of black line is representing how much contact surface area you have. And it makes sense. If you put two surfaces together, and it makes sense, right? If you put two surfaces together that are the size of your hands, you're going to have a lot more stability versus if you put two surfaces together like your fingers, you're not going to have as much stability, clearly, right? And what's going on is that in that closed packed position, outside of the bone-on-bone structures providing greater levels of friction and stuff like that, you're also going to be where the ligaments are furthest apart. The primary ligaments are going to be the furthest apart, and thus they're going to be taut, right? Like it's going to be rope pulled tight. It's going to be, it's a very tight surface. Good example is when the knee's at full extension. The open packed position is where joint ligaments and structures are actually in a slack position. So they're not taut, they're not tight, and it allows more freedom of motion and less stability, and the ability for distraction is possible, and the ability for maximal distraction is possible. And one way that you can kind of simply try this out, which isn't necessarily terrible, but isn't great either, just don't go too hard, is go ahead and stick your knee or stick your leg out in front of you. And so go into a complete knee extension position, and then try to push your shin in either direction. Try to move your tibia and your fibula around in either direction. You can't really, but then if you relax and move into a slight flexion, but a non-weight bearing flexion, you actually have, and you'll see, you can actually move a higher level within that joint. That knee joint is not as stable. And so distraction is the ability to move the joint in various directions. Cool. So we just talked about how much joints can move. How do we actually measure it? One of the primary ways, you can use video. Video data capture and video capture is a very good way. You can do stuff like Vicon, and if you ever watched the show Sports Science for the kids that were born in the 90s still, which is very few of you, or even the 80s, I guess, you can use video capture. A more common way and a lot cheaper way is to use goniometers. So essentially you have a hinge that you place at an axis of rotation. You use a stable or a more stable stationary portion of the joint. In this case, this would be the femur, and this would be the tibia fibula. And you rotate the less stable, less stationary joint about the axis of the goniometer. So about the axis of rotation for the joint. And then you measure what the angle of change is. Don't forget, there is one more slide deck for you guys to go through. That slide deck has movement terms, and rather than sit there and just burn through like 50 slides of me acting out motions and stuff like that, I figured it would be better for you to go through and study those on your own. So as you're going through those, make sure you're learning the motions. Not this week when we're in class, but the next time we're in class in a couple of weeks, we're going to probably act out some of those. Like you'll be responsible for drawing cards and stuff like that. And then we'll also start working a bit on some of the assignment type stuff. Sound good? Awesome.